Okay,
Okay, Matt, can we start? Hello. Assalamualaikum. Good afternoon in KL, but it's going to be good morning to people in UK Ireland and good evening to people in Australia. So it's kind of like a very interesting, and I'm so excited today actually. Why? Because this is the first time that we managed to invite Malaysians who stay overseas. Why do I do this? We Malaysian in Malaysia, not enough, not good enough until we have to invite people from Malaysia to talk about mental health. And then most of the discussion on mental health in Malaysia on a day after Malaysia Day. What? So why we always look up to people outside Malaysia? But that's not the reason why I choose uh, the panelists for today's discussion. In fact, as a Malaysia Day is a special to me. Why? Because I was born on Malaysia Day. So Malaysia Day, I supposed to enjoy my birthday. Yesterday I did, but today is start working already. That is not good for my mental health. But when we do something that we love or something that we find is so important for us to do, it's not a work. It's a it's a calling. And then I enjoy doing this. Some more, I'm going to have a sharing with the person or the people that I like to spend time with, even though on Saturday. Okay, I'm going to introduce to all of you one by one because I don't want to kind of like shock to see three of them at one time, one by one, yeah, because they are going to be someone I think going to make some changes in the mental health settings. It's either where they work now, and maybe we are lucky enough for them to come back and do some changes in Malaysia. So that's the reason why I choose them today in conjunction with Malaysia Day. I think that's the reason why we have these people in our list of panelists. The first one is my used to be my student. Now psychiatrist, already qualified psychiatrist, but he took the challenge to go overseas, to go to UK and become registrar. Actually, it's a demoted rather than promotion. So why don't we listen to Dr. Lu? Dr. Lu, well, happy to see you here, Lu.
Hi,
Can you
happy to see you here too.
say hi and introduce yourself, Lu? And then
Sure, sure, yeah.
tell us also where you are now.
Okay. Hi everyone. Okay, nice to meet you here. So, I'm Lu. Okay, in Malaysia, usually people call me Lu or Dr. Lu. In the UK here, people usually call me Jiann. So by the first name. So, I'm currently working as a psychiatrist registrar in Wrexham, and here, I'm now in a place called Powys, a nice place to spend. I mean, a day. It has castle, it has garden, and I have been here for the past 2 years and in Wales. So before this, as Dr. Hazli has mentioned, I was his disciple. Okay, he's a great mentor. I can tell you that. And I have worked in Malaysia for a few years before I moved to the UK to go through my higher training here. And happy belated birthday to Dr. Hazli also. Okay. Anything else you want to know, Dr. Hazli?
Yeah. So
Or
how long have you been there? How long have you been working there?
I've worked in the UK for the past 2 years. This is going to be the third year. And I work in both general adult psychiatry setting and also old age psychiatry setting. So because here there are different specialties and all specialties deal with different patient groups. So I'm currently working with the older adult and also the general adult group.
I see. Okay, Leo, before I introduce our second panelist here, what
Hmm.
do you miss about Malaysia? What the
Oh,
first thing came to your mind when I asked that question?
Makan, makan, makan. Malaysia has the
Any
best
specific
food.
makan? Which food that you miss right now?
A lot. Okay, the national cuisine, nasi lemak, roti canai. These are something that I will never forget, and this will be the, I mean, first thing I will do when I touch down in Malaysia.
Okay, thank you, Liu. Let us uh, get acquainted with second panelist, Dr. Fahmi. Dr. Fahmi, I know him through Facebook, and then I managed to meet up with him in physical setting last month, I think, when he came back. And I always want to ask his experience because he always worked outside Malaysia. And let we hear from him himself when he's introduced who he is and where he works right now. Yeah, Dr. Fahmi, can you share with us a bit about yourself?
Yeah, Assalamualaikum. Hi everyone. So, um, I've been in Ireland now over the past 12 years. So I finished my undergrad studies back in 2009, and then went straight into psychiatry and completed my training back in 2018. So I suppose in Ireland, quite similar to UK, where when you train, you kind of subspecialize into a very, I suppose, specific subgroups. Like I was a kind of consultant in the community adult service for about 5 years, for about 4 years, and then I took another role now at this stage, a subspecialized role in cancer care. So we're a mental health service that deliver mental health kind of for patient with a cancer diagnosis. Um, so have been here for 12 years now at this stage altogether. And I suppose just for FYI that I haven't worked in Malaysia, so I won't be that familiar with the mental health service and deliveries in Malaysia. But I'm more than happy to share some of the things that I suppose that I think that it work well here in Ireland, hopefully for future for Malaysia.
Thank you, Dr. Fahmi. Well, now, Fahmi, what did you do when you uh, arrived in Malaysia during your break recently?
So I suppose because COVID time it was hard for everyone, so we haven't been home for a while at that stage. So a lot of time spent mainly with the family, and then traveling around, and of course same as Lou, that we spend a lot of time eating, makan. So
Uh,
we usually have a
but
list of food that we'll try to eat anyway.
okay, and then last but not least, this individual, this person, I admire her for her courage and her uh, passion in whatever that she's doing. Let me introduce Miss Tan Sumay, and I want her to introduce herself to all of you because I don't think I will do justice to introduce her. So let her do that. Sumay, please share a bit about your background. Yeah.
Hi everyone, my name is Sume and I'm speaking to you from Melbourne, Australia. Uh, I got into the field of mental health through art therapy. My first degree was in architecture, where I studied in Cardiff, Wales. But very soon after that, I realized my interest and my connection with art was actually an emotional one, and I was more interested in what goes on inside a building rather than how a building looks like. And I did another degree in World Heritage, because I was really interested in what all the different traditions are around the world and the different cultures. And that led me to come to Melbourne to study a master's in art therapy. So I'm an art therapist. I'm also a family therapist and a yoga therapist. So I'm currently pursuing my master's in clinical family therapy, and I work full time in family therapy, um, although I'm yet to complete my master's. My day job in family therapy revolves around working with families who have adolescent and teenagers who have challenging problems such as violence, drugs, self-harm, and other challenging presentations, and we equip the parents with strategies of how to improve these behaviors, because we believe that how someone reacts towards a certain situation or trauma has a greater effect than actually what has happened in the past. In art therapy, I run a private practice called Art Therapy, where we do art therapy, family therapy, and yoga therapy. And with art therapy, it's more about a psychotherapy discipline using art materials such as drawing, painting, sculpting as a means to express oneself and to process difficult situations in your life, and also to provide a catharsis of release by making art, and to have some relaxation in your day-to-day life. And in yoga therapy, we use the body and the movements of the body to release both physical, mental, and emotional tension in the body, mind, and spirit.
Wow. Okay. That's the reason I said I have to ask you to introduce yourself, Sume, because I can't do that, right? Because it's to a lot of things that you have done. Okay, Sume, what I know that you just came back to KL recently. What you miss once you step your foot back to Melbourne? What did you miss about Malaysia besides your parents, though?
Well, I actually miss the community, the Malaysian spirit of the way everyone helps each other out, the kind of the ground level unity between the races, no matter what the higher powers are trying to do. There's a huge amount of unity on the ground level where everyone kind of has a mutual understanding with each other, no matter what background, culture, or religion that you come from.
Oh my goodness. Sume, is you kind of like uh, tell everyone the summary of whatever the discussion that we're going to have today. You sum up it so well already. That's the whole. I thought I want to come up with that statement, but you already said in the beginning. Okay, thank you so much. Okay, the whole idea about this actually happened when we have a discussion during Independence Day. Myself, Retina, Emilia, and Faiz, Dr. Faiz. And then somehow I found that it's kind of a very good sharing when we exchange our idea besides, focusing on so much on the treatment and then the medication on the only the conventional psychotherapy, but we know our patients, our clients need more than that. And more important also, for hopefully our discussion will encourage people to find out more about the services that can be provided for patients, and then the potential career pathway for them, not just to be a psychiatrist or clinical psychologist. And today, Sume is the example of that. In fact, Lou and Fahmi, she did more work than us. Yeah, she got how many job description that she has. And the whole idea is it's important for us to get the training that accredited for whatever that we want to offer, right? Okay. Uh, okay. Feel free to ask each other question if you want to ask. Yeah, I'm not the one who's going to ask question. I'm not. I really want to hear from three of you. Yeah, about your thought, your opinions. Yeah. Can I start with Lou? Yeah, Lou. So when you first joined the employment, being employed in UK compared to what you used to, are there any big cultural shock, or are there any big challenges that you have to face to adjust yourself to the new working environment there? Lou, are you there, Lou?
Can you hear me now?
Lou? Yeah. Now can yeah.
Yes. Okay. Yeah. One thing about Wales, especially North Wales, is the internet connection is haphazard, even at home. So can't fix it at the moment. Sorry, Dr. Hazli, would you mind repeat the question for me, please?
Okay. What are there any were there any challenges that you have to face moving from working in Malaysia and to working to different system? Any were there any challenges or any cultural shock, or it's quite easy for you to move from one system to another?
I suppose the answer is both yes and no. So, working as a doctor and working as a psychiatrist in the UK is not different from working as a doctor and or psychiatrist in Malaysia. So, because we inherit the system from the British government before. So, overall, the healthcare delivery system is quite similar in one way or another. Um, like in the UK, so the services is being delivered at different tiers at the primary care level, secondary care level, tertiary care level, and quaternary care level. And any specialized service are secondary and above usually. So uh, one of the perhaps one of the different things that I find relatively difficult here is basically your GP or general practitioner is the most important person in a person's health. So everything of a person's health will need to go through the GP. So GP is the most important care provider for a person throughout their life. So I think this is a main difference. For us in Malaysia, I would say it is very accessible for us to access healthcare. So you can walk into any clinic kesehatan and you can see the doctor on the same day, which is not happening here in the UK. You have to make an appointment, which the face-to-face appointment, especially after COVID, it might take 2 to 3 weeks, or sometimes after the automated answering machine, you can't even see the doctor. What you get is basically some advice online over the phone, and then that's it. And if anything emergency, then you just have to attend the emergency department, in which you can wait for maybe 8 to 24 hours just to see the doctor. So I suppose this is a challenge that we face here. We might think the UK has a lot of resources, very well equipped with staff. We have everything here. In reality, because of the level of specialization here, it brings out both advantages and disadvantages. So what happened is the care is so specialized to the extent that some patients falls between and their need are not met. So I suppose this is another challenges that faced by the current system. So coming back to the question of do I have problem with adjusting to the new system from Malaysian practice to the UK practice? As I mentioned earlier, the system are more or less similar. It's more of the adjustment to the local culture. It's a cultural adaptation, how to speak like a local here. How do they express disagreement? How do they break the bad news in the UK way? So this is the only difference, I suppose.
Okay, thank you. And do you have to do it differently in Irish way, Fahmi? So I'm just wondering, how about the system in Ireland? Pretty similar to in UK as well, or slightly different? Fahmi, in terms of general practitioner and also at the
Mm.
secondary care level.
So I say kind of Ireland kind of mimics a lot with the system in UK. I suppose there's a slight variation, I would say, in terms of, I think just for kind of I suppose for people to be aware of in GP. Like general practitioner in Ireland, UK is actually a training process. So there's a training pathway to be a GP. So they're almost like family medicine specialists, in a way that you have to do, I think 5 years training altogether to become a GP. and you have to be in a specialist register as a GP. And what they do is that they each, I suppose, individual should have a GP allocated to them, and the GP also they deliver all your care. So, for example, one family, like family of five, might have a GP. They're the one who take care of your children and your health. And I suppose if you're seeing another specialist like secondary care or tertiary care, all the communication from those hospitals will come to the GP and they will follow up on that. Like a KK, like Klinik Kesihatan Malaysia, where they manage diabetes, where they hand over to KK to follow up. So the GP plays a huge role in terms of delivery care, in primary care. So I suppose in mental health, then they tend to manage, I would say, simple, I suppose not simple, but people with first episode of depression, anxiety. So those kind of less enduring illness, what we call them. And they tend to manage them first. And after they tried several medication and they find that the patient are not responding, and then they'll be referring them to secondary care or in a psychiatry. So slightly very similar. I think one of the main difference in Ireland is that our primary care is actually not developed. So we don't have community social worker. We don't have a community psychologist. We do, but very, very, I suppose the numbers are very small. So we tend to get referred a lot into psychiatry. And the threshold of referral tend to be quite lower, I say, compared to UK. And I do think that our access to a secondary care is probably better than UK, because I know like in UK that if you present it with self-harm in ED with some depressive symptoms, they tell you go to website and do CBTE that kind of way, and then come back to the GP. So they have that kind of process that they ask people to use whatever in primary care before accessing a specialist care. So very similar, but primary care very underdeveloped in Ireland compared to UK.
Yeah, yeah, very interesting. I think that thank you for both input. Sumay, I think you work more with primary care with GP than psychiatrists in your setting as well, right? And then, what do you
Not
think
really,
about the role?
actually.
Huh?
Not really, actually.
Not really. So can you
No.
share a bit about how the role of primary care and mental health, and how you fill up the gap, or how you mesh or fit into the system with your specialty?
Yeah. So, I would say primary care in Australia is pretty well developed. It goes through the GP as well. If you want to go see a social worker, psychologist, or psychiatrist, or any kind of specialist doctor, you would need to go through a GP. And here in Australia, we have Medicare, which is government funded medical services, where if someone has like some mental health challenges, you can get like 10-session mental health care plan from the GP, and that also can include social workers. However, family therapy and art therapy alone by itself does not come under the mental health care plan. Um, Apart from kind of standard mental health, there is also the National Disability Insurance Scheme here in Australia, which is specifically for people with disabilities of any sort. And if you have a disability which is kind of, um, I would say, maybe what they deem as severe enough, then you can get like a pretty much almost a lifetime package of uh, of care, and the National Disabilities Insurance Scheme will cover things like psychology, counseling, art therapy, music therapy, even covers like equine therapy, like horse therapy, and it also covers things like disability support workers to bring you out in the community to go do shopping and stuff like that, and speech pathology for those who need it. And so in Australia, predominantly art therapy comes under the National Disability Insurance Scheme, and my private practice art therapy is a provider under that scheme. But you can also access art therapy through other sorts of funding, such as family violence funding and that kind of thing. But my day job is funded through the reunification scheme, family preservation and reunification, which is aimed to kind of reunify families that are at the brink of being separated. Because Australia has a long history of especially Aboriginal children being separated from their families due to different sorts of challenges. And the Australian government now is trying to keep families together rather than take them apart and put them into foster care and resi homes and stuff like that.
Okay. Thank you, Sumi. I want to ask all of you, yeah. Let's say that I have panic attack for the first time, and then I did some reading, and I know it could be related to anxiety disorder. And then I want to get help. And how easy for me to get access to help? And then what is the pathway for me to get help in Ireland, in UK, and Melbourne? I know, Sumit, that you can imagine that. I'm not sure whether if you not able to say that. I'm pretty sure that you know someone who who need the help, right? I'm just wondering how easy for us to get the services, and then are they the system help us to get all the benefit as mentioned by Sumi just now? You know that how can we get the assistance for us to get the beginning for the treatment. Fahmi, you think
Yeah.
that's very easy for me to get the appointment to see you in Ireland, or I have to wait 3 months or 2 months or 6 months before I can see you?
I say surprisingly, usually this will be managed by a GP. I do have expectation for the GP to manage this themselves for first episode. So the GP probably it'll take you a week or two to get an appointment. If you end up coming through ED due to non-cardiac chest pain, and sometimes you can have severe panic attacks that mimic a heart attack. They end up in the emergency department, and you'll be seen quite immediately then by on-call psychiatrists. So there's two pathways.
Meaning the GP can help me, right?
So you have two pathways. So you know that there's some
Mm.
patient who comes into the emergency department with non-cardiac chest pain, turn out to have a panic attacks, which they're very similar. And they will be seen quite immediately in emergency department by usually a registrar, psychiatry, who probably will commence the medication and refer to the community mental health team. But if the person doesn't go through the acute pathway or the emergency pathway, they go to the GP pathway. So you might take a week or two to get a GP. Some GP can offer immediate the same day, usually probably same day, because it mimics some form of heart condition. So and you get, I suppose, if there's any treatment warranted at that stage from psychopharmacology point of view, you'll be commenced quite soon after that by the GP. GP
So we
also
have
can
to
refer.
so we have to pretend that we have heart problem to get earlier appointment.
I suppose because they comes with like a heart condition, they tend to be seen quite
Just
soon
kidding,
anyway.
just
Yeah.
kidding.
So I say a day or two definitely by GP, and GP can commence the medication in general, at that stage.
Yeah. So how about in Wales?
Um, it's quite similar with what Fahmi has described. So I suppose there are two pathways here that I categorize it. I mean, broadly. First is the GP pathway. So if the person is feeling anxious or having panic attacks and not to the level of emergency, what usually they will book an appointment with the GP. And of course, another pathway is the acute pathway. So calling 999, either go to the emergency department or calling 999. Or another choice, which is not emergency but something urgent, is calling the 112. So sub-acute, I would suppose that way. If they present to the emergency department and they are seen by the liaison service, so usually it is a nurse-led service. So they'll be assessed by the liaison nurse, and from there they'll be triage. So to see whether further assessment by the psychiatrist is needed, or they can go back to the GP for treatment. So coming back to the question of how accessible is it, So it depends on the presentation, number one, and it also depends on the availability of service at that moment also. So, for example, in Wales, there is no such thing as online CBT. So, if you book an appointment with the GP and then for panic disorder or anxiety disorder, you'll be seen, and it can either be seen by the specialized nurse practitioner if the GP has those services. So the nurse mental health practitioner can assess and then after that provide treatment directly, and or the GP will be the one provide treatment directly. And if it is further, further needs arises, then they'll refer to us. And then in the secondary service, we will have triaging. So to determine whether the person needs to go to the primary care service in the secondary care, realm, or if further escalation is needed to more specialized service. So it's quite complex here. So in a nutshell, two choices: GP or emergency department. So, and if calling 999, the ambulance has come. So the assessment happened that way, there and then. So immediately, most of the time, they can rule out cardiac cause. So what will be the endpoint usually is go back to the GP again, or go to the what I said, specialized service. So it depends on the ambulance assessment.
Okay. Yeah, that's for the panic attack anxiety because that is really similar to heart attack. We need to rule out the physical condition first. Normally, we'll get the attention fast because of the emergency cases that related to heart. Yeah. So, May, from your experience, other people experience, right? How easy to get access to care for those who develop depressive symptoms? Depression, and then they think that they may have depression and then they want to seek help. How easy for them to get access to help in Melbourne?
I think there's a lot of pre kind of services before someone goes to a GP, because like in Australia we have a lot of helplines, like free emergency counseling helplines, either for just general mental health, suicidal ideations, or even family violence specific helplines that they can call. And then later on, and obviously we do have like emergency services as well, like the CAT team and 000, where people can call for an ambulance to come. But there are all these kind of 24-hour service helplines that people can go to. I think the challenge in Australia is that with Medicare, I don't know about in the UK, that the government only subsidizes a certain amount. So like there can be scenarios where a lot of places they charge higher than that, and for people who only want to pay what we call bulk bill, which is where they don't pay anything at all. There's a very long wait list for all these kind of GPs, and especially psychiatrists as well, and psychologists who just charge within the government stated amount, because a lot of the time people are charging above that, and people are not used to paying out of pocket. I feel like in Malaysia, like, yes, there's the government service, but like if people go to a private doctor in Malaysia, it's expected. I hear psychologists in Malaysia charging almost the same amount in Australia, or even higher than in Australia. Whereas here, people have that expectation that the government need to look after their health, so they're not really willing to pay out of their own pocket for these sort of services.
I think the government should look after their
Yeah.
citizen.
Yeah.
So
Yeah.
I think I know
But
what
then
you're
there's a
trying to
long
say.
wait list. Yeah.
Yeah. Yeah, I think the interesting to see that there are more and more services before go to psychiatrists, for example, because not many psychiatrists, because it's considered as tertiary or higher, right? That's what happened in Malaysia. It's supposed to be more and more, level of support available before seeing a psychiatrist because the limited number of psychiatrists, limited number of clinical psychologists. Unfortunately, the frontliner, the primary care not being supported enough, not being empowered enough to cater for the simple cases, for the early early stage of the condition which can be prevent from seeing the limited resources like psychiatrists, clinical psychologists, even the art therapists. It's more like a very expensive services in Malaysia. So if you come back to Malaysia, you can even more richer, much more richer. You can charge even higher than psychiatrists.
I'm not
You know
interested
why? It's
in
not
working
because
only
you
with
know why?
rich
Because
people.
there is no regulation for art therapists, but there is a strict regulation for the fees for the doctors and counselor. Because psychologists is not there yet. That's the reason they can charge higher than Australia. Though I think what I get from all of you, yeah, the importance of primary care, the importance for us to empower the primary care and then make much easier for the accessibility through the system, through the how to coordinate care, uh, before we go even higher to the secondary and tertiary care. So that's what we need. That we want to do that. We want to let the people in Malaysia know. Please ask our government to empower the GP, not the psychiatrists. I think we want the GP first, the frontliner first, but we have to work together with them and other service providers as well. You guys, you know that we have a lot of questions, you know. So most of the time that when I do like this kind of forum, not many people ask questions. We have a very very good audience with us. So the first one, the from Noshima. Hi Shima, how are you? Shima asked, does UK not have not have private hospital? Do we have to make appointment to see doctors there too? I think that's applied to UK and Ireland, right? And you have a private psychiatry setting, right? I mean that the private services for mental health, right? And do they have to make appointment to see doctors there? Lou and Fahmi? I'm pretty sure it's applied to Australia as well. Yeah. Private
Shall I go first
hospital,
or
private.
Fahmi?
Yeah, go ahead. Yeah.
Yeah. Lou can go first. Hi, Lou. Can.
Sorry, am I still there or am I frozen?
No,
No,
yes.
you move. Yeah. Can continue talk.
Ah, okay. I'm not too sure. I'm frozen. So, okay, yeah, in the UK, we do have private hospitals and also private mental health services. And of course, private means that the payment comes from the pocket itself. And the population here are not basically are not familiar with this system usually. So because the NHS is quite, uh, quite well resourced in the past. So most people relies on NHS alone, and it is not actually something common for people to go to the private unless the NHS cannot provide that service. So this is number one. So they do have private hospitals, and yes, everything here go by appointment. So you can't just walk in and see a doctor. So an appointment still has to be made. And of course, in private setting, the appointment will be much earlier compared to the NHS, relatively. And coming back to the payment part, so there are insurance health scheme too. However, healthcare insurance is not as affordable compared to Malaysia. So the healthcare insurance here are very, very expensive. Plus, they are very specialized. What does it mean? It means that you only buy healthcare insurance that covers certain condition or procedures. They tell you very clearly. So the list of procedures that are covered in this insurance and the list that are not covered. So I think you can imagine how expensive it can be if you are going for long term private health mental health care in the UK.
And as mentioned by Sumit just now, like Australian, they expect the government need to cover for that, right, Lou? So because that the expectation of the citizen that is the role
Yes,
of the responsibility of the
of
current government, I mean the government to do that. And that is
yes,
also the same in Ireland for me.
Yeah, I think just to kind of comment about that, I suppose the expectation of the population for the government to deliver the service probably comes with the amount of tax that they pay. So that's the reality of
Okay,
it. You know, people who tax heavily in a lot of these
true,
countries.
true.
So the expectation they get their value back by getting those services that should be provided by the government. Just to get back to the question, so and we're lucky in Ireland that the private services are not really that established. So we have only one kind of private hospital that runs in Dublin that takes a private admission, and the community for private services are kind of non-existent. They are, but they're very little. They're solo practitioner, which if you think about mental illness, people with enduring mental illness should be managed by the community services, where you have nurses, peer support worker, you have employment support officer, you have kind of varieties of services provided for you, which private services won't have any. So a lot of time that they won't take anyone with severe enduring illness anyway. So if we have schizophrenia, bipolar illness, they won't take them because they're not really designed for them. So which kind of nice working in the public in a way. There's no two-tier system, which kind of it makes it more there's more justice or equitable. The equity of the services are a lot more clear, I suppose, in Ireland. So you can still see a private psychiatrist. The waiting times actually probably 6 to 12 months now in Ireland. So for private psychiatrists, they're very rare. It's very hard to get one. But I think the public services are a lot more accessible and probably a lot better at delivery of care for people, for patients who need mental illness. So it's easier in Ireland, I
Yeah.
suppose. It's clear.
Uh, okay. This is question from N Yuan. I think this is Datin Ann. Is your mom, Sumay, I think, right?
Yep.
Okay. Uh, Datin Ann want to know the challenges faced by consultants overseas as compared to Malaysia. So I think maybe Lou and Sume can answer this because for me it's a bit hard because he have not had an experience, right? But I think he probably know from his friend that complained a lot to him about services in Malaysia. But I think Lou and Sume, what are the challenges faced by consultants overseas as compared to in Malaysia? Because we thought that working overseas is easy, got more money, but well, sometimes can be challenging as well. Yeah. Sume, what are the challenges you yourself face? And then you think that the other service providers that you work with that found the challenges that they face day to day in their
Challenges that
work.
I face
Mm.
because I'm not a consultant.
Yeah, I mean that you are. I mean the in providing the services.
Yeah.
What are the challenges that you have?
I think one thing I find tough about a welfare driven country is that some of the families and some of the individuals are so entrenched in, relying and kind of expecting to be supported, and it's kind of like a chicken and egg thing where they are like, say, like with the NDIS, the National Disability Insurance Scheme, which is not private health insurance, it's a government funded thing. They need to constantly prove that they are impaired. And I'm not saying that people with disability will one day not have a disability, but there is potential for people to kind of understand their symptoms and be able to kind of lead fruitful lives. Whereas, like with the National Disability Insurance Scheme, they need to, whenever we, as what you call consultant, write a report, we need to keep saying that, oh, they're facing this and they're still not doing well in this, and constantly saying that they haven't gotten gotten better in order for them to keep on receiving that funding, and for people to keep on um yeah to for people to kept being reliant on it, especially in the financial in the financial way, such as receiving payments from the government if you're not working. And yeah, that is tough.
Yeah.
That is tough for me to see, because I think Basil van der Kolk said, who's a trauma specialist, said that one thing that sometimes prevent people from kind of living a fruitful life beyond trauma is the fact that they're kept on relying on these supports. And
How to make
it's not
them.
that I don't think that they should have those supports, because obviously it's a good thing, but to keep on relying on it is very challenging for me to see, for families who have gone through it over several generations relying on it.
Yeah, because in a way, if I understand that correctly, Sume, sometimes they kind of like discourage them from push them for the full effect of whatever treatment or support that they should be able to achieve, afraid that they may lose the whatever financial assistance that they being offered, right?
Yeah,
I think we need the system which also giving some kind of financial assistance when they are able to function and
yeah,
get out from the disability or the impairment that they have, right?
yeah.
Yeah. That's a thank you for brought up that uh, very interesting point for me. Yeah. How about you? How about UK, Dr. Liu, any challenges that you face besides just now the languages, besides the culture? What else that you find that can kind of like difficult for you to face, especially you have to do that day to day in your day to day practice.
I suppose the limitation of how much you can do by the system, basically imposed by the system, is the main challenge here. So in the local practice, everything is based on guidelines, policies. There's, I mean, written by someone, and if anything that is not according to the guideline is something that you need to defend very hard. So it kind of limits your creativity and innovate. Innovation in one way or another. So because here the local culture is about safety and prevention. So everything must be very safe. So there are a lot of mechanisms to make sure that the process, the policy, or the procedures are safely delivered up to the standard prescribed. So because of those mechanisms, it creates certain limitations that how much you can do beyond the boundary. So, and we do know that mental health problems are complex to begin with, and no one size fits all type of solutions for every patient. So what happens if it is not in the book or on the policy? Then what can we do or can we offer? So this is something challenging here. So everything follows the guideline. If anything that does not fit that, sometimes we can't do anything. So this is the problem, or else your license will be at least at risk. So it's a balance of how can we do it differently, and also how to do it safely. And like for example, I give a simplest example of giving short and simple CBT to a patient who you know the patient is that have panic attack, doesn't need long treatment basically. Can I do CBT in the clinic? The answer is no. One simple reason: I don't have CBT license in the UK. So, and to give CBT for 1 or 2 sessions is not allowed. If you want to give CBT, you have to give full CBT, then you can call it CBT. So, or else you have to basically back everything you do with evidence, with policy, with guidelines, or else is something not, the mechanism won't protect you. So this is, I suppose this is the main challenge of the system.
Yeah. So it's in a way it's a restrict a little bit more restricted in terms of how to be more creative, as you said. It's not to be on not safe side because you still follow the standard, but somehow that you mix and match. But unfortunately, that's not according to the standard or guideline, which you're going to be at risk if anything went wrong,
Absolutely.
even though it's not really related to what you did. Yeah.
Absolutely.
So
Absolutely.
yeah. So yeah, that's thank you. Very good point. I thank you for both points actually because it's really opened up some idea for me. For me, I know you said that island system is perfect. I know
I
that,
didn't say
but no, it's not.
that.
There is no such thing as a
No.
perfect
Yeah.
system. Yeah, that I'm very sure of that. But again, what are the challenges you face as a psychiatrist, yeah, in Ireland that you may that other people may not realize, yeah? Like for
Hmm.
example, psychiatrists in Malaysia do not realize that you have to face day to day.
So I suppose I probably echo what Sume mentioned there just now about expectations. I do think that public have these expectations that they get, access immediate, and this expectation was built upon, I suppose, a policy that was provided by the government. So a good example is that one of the rules or one of the thing that was part of the requirement is that someone admitted to the hospital need to be seen by a consultant within 24 hours. So they have those kind of guidance documents. I suppose it's a consultant-led services in Ireland. I'm pretty sure in UK is quite similar. So there's a huge, I suppose, pressure and the burden of the consultant to lead the service from governance side, leadership side, service improvement, and also from the clinical delivery. And there's expectation for the consultant to be quite hands-on in delivering those cares. So, for example, if someone new to be seen in the clinic, they should be seen by a consultant for the next review. So they have those expectations that built into the delivery of care, which put a lot of pressure because a consultant might be managing like 70,000 population. So it can be quite huge in psychiatry and managing around 40 staff members. So, and sometimes what you kind of notice is that as a consultant that you try to balance between, managing clinical care and also trying to spend a bit more time or protected time in service development, because if you don't develop your service, you get no money and you get no expansion. And sometimes what you see is that the services are all the time spent in clinical care and the services stagnate. It doesn't improve over time. And that's quite challenging. And the other thing is, I think as a consultant as well, your managing team, especially in psychiatry, is hard. If you imagine managing a MD team members 40 people, they're actually quite challenging at times, and you have to play a lot of different roles from, leading them to managing conflicts. So there's a lot of that piece that are non-clinical that sometimes, you prefer not to do. So
Fahmi, does the financial reward can compensate for that for the challenges?
I suppose I would say, funny enough, in I suppose money is not really an issue. Really, I do think that in I suppose, and most of my colleague will agree with as for me in a lot of ways, because a lot of people doesn't know that the since 2012 the consultant salary was cut by a third, so we get paid a third less than some of our peers that working, but it never really come
But
out.
and the but the workload still the same.
Same, yeah, we be working the same, yeah, yeah. But surprisingly, it never been an issue between our peers anyway, as an issue, because also financially, it's actually as long as you have enough, and that's the end of it. It's not how much you need and how much money do you need anyway nowadays. So I think the job satisfaction probably, and I suppose to be able to deliver care that you're passionate about, probably more important than salary itself. So.
Okay. So May, do they pay you enough?
Hmm.
The financial, I mean, is
Well, I'm sure I'm not
is
making as
rewarding?
nearly as much as consultant psychiatrists are making, but it's enough for anything that I need, I would say. Yeah, like
Mm.
my day job, like I work my day job full time, and then I have my private practice on the side where I employ now 3 different art therapists. So as long as I can pay their wages, I'm happy. Yeah.
Okay, so you're doing good.
Yeah. Sorry?
I mean, you're doing well then.
Yeah, I guess like I would say if I was only relying on my private practice, it's quite challenging because the nature of the NDIS is that people cancel a lot, and they're required to you know they have their own mental health challenges, so sometimes they cancel and things are a bit more infrequent. So like, I'm not so brave enough to go full time into it yet. Yeah.
Yeah. But I think one thing that we share in common, right, for all the mental health professional, money or financial reward is not the only reward that we are
No.
looking for, right? Yeah, so job satisfaction, the ability to make the changes. So that is something that people have to know, so they cannot accuse us greedy, one for the money, one looking for money, and then financial reward, and the only thing that satisfies us. That is something that the true mental health professionals is all about. Okay. Um, Sumay, what do you think that the services or the facilities in Melbourne that you think is worth for us in Malaysia to try to have or try to set it up from your, I know a lot, but just give me one or two example of that.
Mm, in terms of mental health services,
Mhm.
I think one thing that Melbourne does quite well is this concept called park. I can't remember what it stands for, but it's like an in between. It's like a residential setting, which is not hospital. So like a lot of times people who have significant mental health challenges who need to be hospitalized, they're unable to stay in the hospital for too long. So here we have like another residential setting, which I believe is government funded as well, which called Park, where they can, go there, be safe, be kind of mildly monitored, not to the same level of being in a psychiatric ward or anything, but like it's like a, a residential setting where they can be safe and with other people, and they have like lots of different groups like art therapy, music, and that kind of thing. They can go there.
Yeah. Okay. Nice. Okay. There is one question from Dr. Ratina. Yeah. Hi, Dr. Ratina. Okay. As a dear panelists, what are the examples of effort by the government, society, or private entities at your respective places to train the GP to identify patient at early stage of mental health issues, so proper referral pathway is formed? So, are there any effort to help the GP, to empower the GP, to upskill the GP in Ireland or in UK? And Fahmi, want to start first?
Okay, I suppose I'll start off with as in GP training first. I suppose
Mhm.
in Ireland, as part of GP training, they are compulsory to do 6 months rotation in psychiatry. So that's one thing, that how they train the GP, that making sure the GP able to manage any, I suppose non-complex mental health presentations. So it is incorporated into the GP training. And I suppose that helps a lot for the GP, because when they come out as a GP trainee, they probably be quite comfortable to manage like panic disorder or depression, because they have been, I suppose, rotated into community led team, and have been running clinics themselves as well, together with consultant supervision. So I suppose that's one way how they integrate or they empower the primary care GP to be able to deliver I suppose, mental health service for a non-complex presentation. Outside GP, then there are other national programs that are running in terms of training the GP and also creating a different pathway in primary care for them to be able to access. There's quite a number of them, like similar to Australia. We have like Pieta, who actually do a lot of kind of the referral from a GP for suicidation, self-harm presentation. So they do that. This primary care level, there are few, I suppose, agencies and resources that are designed to take referral from the GP before being sent to secondary care. So we have those kind of before secondary care, after primary care kind of services as well. But I do think that incorporation of a training in mental health and psychiatry as part of the GP training will be quite beneficial for the from definitely from Malaysian perspective, So that will be the only point I'd say.
Yeah. Before Lou comment on that question, yeah. So I think in Malaysia and the GP, I'm talking about the private and on the public setting, right? The public setting, the GP, they have too much work, and then they have to look so many other chronic diseases, and then their exposure in handling mental health also limited. So when we empower them with all the knowledge, right? But we also need to provide them enough time for them to cater and then look after the mental health issues in primary setting. It come back to more and more GPs and more people in the clinic kesihatan need to increase the number of doctors. And then funny enough, we have so many doctors that under contract not being absorbed into the permanent post, and then we have a limited number of resources, the number of doctors in primary care level. So it kind of like interesting. We have a lot of supply, but we claim that we don't have enough people to serve in the clinic kesehatan. So again, it come back to how to make full use of the supply of doctors that not in the permanent post into the GP, and then equip them, empower them, upskill them so that they can manage more and more cases like mental health cases in primary care, right? So that is something that we need to do, because we know that primary care is important when we talk about mental health. Yeah, so I think that is something interesting in the private setting. We know a lot of private GP clinic. They also want to focus on other cases, not the mental health. If they want to spend on anxiety, depression, they need to spend a little bit longer, but they need to be financially rewarded for that as well. We cannot expect them to do that, but they still have the similar number of, the consultation fees is the same as other non-mental health cases. So they have to think about their not profit, but the amount of money that they have to make at the end of the month, because that is their source of income. So I think we really need to think about how to empower the primary care, how to empower the GP, and then be rewarded accordingly, or reduce their burden when they want to perform that, because we know the importance of primary care in helping the secondary care. So that is the message that I think that we need to let people know. It's not like the primary care, the GP, the doctors in the clinic don't want to do the job. They want to, but they also too much already for them. And then we need to empower them. We need to refresh their knowledge about handling the cases so that they can handle better. Because the training is important. Because that's what we have to remember to give the train, so the train services. So we need to be accredited for that, because this is a professional services. So that's why, as Sume said just now, Sume show us that need to be trained, that need to get accredited, but we don't want to be too strict, as Lou said, that you have to give the true CBT, you have to give to the true follow the restricted regimented regime for us to offer that. I think that we need a bit of balance for that. Sorry, I just check up a little bit too much from me, but I want Lou to add on in terms of are there any effort or program to help the GP to be more familiar, to improve their skill, or to refresh their knowledge about mental health so that they can help the secondary care?
Maybe I can put it this way, rather than upskilling them, they are already skillful to begin with. I'll put it this way. So the general practitioner is that, as what Fahmi has mentioned, they have training in mental health during their GP rotation. So they are not new to the mental health conditions and treatment at all. So they are quite skillful to begin with. I suppose it's about collaboration with them. So in the UK, so every GPs are as similar like Malaysia also, they have rotation in psychiatry. So they learn how to prescribe, they learn how to diagnose, and also they learn to do basic therapeutic intervention uh, in clinical setting, especially in the outpatient setting. So they have during their training phase, they got it already. So when they become a full-time GP, so what happened is the regular communication with them, I think is a key. So when when they refer patient to us, and then every intervention they will provide, we will feedback to them so that they know what is happening, and if further continuation of care that does not need to happen in the secondary setting, then they can continue with their GP. So this is the first thing. So it's about the communication between the primary and secondary care, or of course the tertiary care. Secondly, so it's about a multidisciplinary team approach. So we have something called cluster meeting. The cluster meeting means that, like for example, the GP has a list of patients with mental health need that they think might be slightly more complex than what they can handle, and then they bring it up in the meeting. And during the meeting, and then after that, both sides communicate like what are the needs that are of the patient and what are the care that can be provided. So it serves as a place for screening at the same time of early intervention too. So if the secondary care deems that this patient needs to come to the I mean, needs to get more complex service, then we get the referral immediately and we give appointment directly. While if the patient, from the discussion, we can identify that the need can be provided at the primary care level, then we can immediately, I mean, communicate with the GP so that the GP, for example, can adjust the medication or make referral to the third sector services. For example, grief counseling, for example, some financial support from the social services. So we have this type of communication platform with the GP. So rather than saying that it's a training, it is more of a communication between the primary and secondary care. So the GP, they are more than an expert and more than equipped with their skills and knowledge in terms of supporting the mental health patient.
It's working together in a team, but at a different level, and that is a both a two-way communication. It's
Absolutely.
not like one superior than another. It's just like equal
Absolutely.
partnership
Yep.
in making the services. Yeah. So Sume, it's not like I tried to get the idea from you. If you come back to Malaysia,
Yes, I
right?
like the word
What are
partnership.
the yeah. So I think this is all to all of three of you. Yeah. It's not like I try to get the idea from all three of you and then I do it here in Malaysia. That's not the intention. Yeah. But if three of you come back to Malaysia and then will be able to do whatever you want to do in order to make a change and then can benefit the patients and their family, what will you do? What services that you want to provide? What business that you want to start? So, who want to to give their future project? Sumay, you want to, to what you want to do if you come back to Malaysia and then with all the experience that you have, what are you what do you want to do?
Are you
If the
asking
money is
what
not a
I want to
problem,
do personally or what I would like to see, like even if it's something that I cannot personally do?
or good, yeah, two aspect, what you want to do personally and what you want it to happen. So it's the same question to Fahmi and Lou, yeah?
I guess for me personally, like I have at the back of my mind starting a training program for art therapists in Malaysia, and if I'm personally involved in that program, I will put in the systemic work around families and stuff. Um, yeah, so I would like to do that. Like even if I don't come back and live in Malaysia, I think it's something that I can still do, and I can even do. COVID has taught us that we can do telehealth and run online sessions. So yeah, time is the issue for me now, but like if I have more time, I'll definitely start offering more services for Malaysians. I did over lockdown have start a Malaysian mental health arts collective, which is not so active now, but it was more active over the lockdown, where it's like more than 10 everyone who had lived experience in mental health, and also artists start that. But on a larger level in Malaysia, I would like to see not something replicating the NDIS, but something along those lines, for for people with psychosocial, physical, intellectual disabilities in Malaysia be more supported in their delivery. And one of the roles that I forgot to mention earlier when Dr. Hazli asked me about, um, what kind of um, service or program to bring back to Malaysia, I thought about my previous job in the National Disability Insurance Scheme, which was a coordinator, where it's kind of like a case manager, where they help find referrals for like all sorts of different services. Because like my previous job was to do that. I was the coordinator, where I would find people a different psychologists, physiotherapists, um, cleaner, gardener, anything like that. Like anything that was under the scheme, I would finding, and I don't see that in Malaysia at the moment, because everyone has to go and find their own services by themselves. Yeah.
Yep, definitely. The case manager we don't have.
Mm.
We JPA need to create that, but we don't need JPA if we can do that in a private setting. Yep, case coordinator, case manager, what we need. We already have the people who can do that. It's just a bit of training and modification so that they can do their job well, and then we together we improve on the outcome or the service that they provide. And the internal monitoring of that is needed. Thank you, Sume. Fahmi, what are the services that you want to set up, and what are the things that you wish that Malaysia can have when in terms of mental health services?
So I suppose I just started a role in a subspecialty kind of services now. So what we're doing at the moment, we are developing a service in cancer care. So we take referrals from other consultant psychiatrists and also from other medical oncologists and all the cancer care provider. For anyone who have mental health difficulties, but that's actually quite far from from basic delivery of mental health services, because they have as a subspecialized at this stage. Actually, my hope is that by the time I'm ready to go home, that there'll be such services or opportunities back home. So just people to be aware that I suppose my team at the moment now recruiting 2 psychologists, 2 social worker, 2 nurses, and we're taking and that's a subspecialty for cancer care. So it is quite, I suppose, it is almost like a 4th level of care really in Ireland at this stage. So it probably would be a while before for Malaysia to be able to be able to develop such services, and hopefully, when the time comes that I'll be ready to go home with experiences from here. I suppose what I was hoping in Malaysia is that looking at people with severe and enduring illness, I do think that, like in any other countries, they tend to be one of the group that with higher significant burden of illness and unfortunately they tend to be the groups that are not, as but they can get sidelined quite easily in society. So I do think that what I think what Malaysia will benefit is that one is that actually more money. So you do need to invest more in mental health to be able to deliver such care. I think in Malaysia they're spending like 1.5% of the health budget in mental illness. I think is very small, and the WHO requirement is 12%. We're actually bad enough in Ireland. We only spend 5%, and I think in UK it's around 13% roughly, I say. So I think this underinvestments in mental health is there's a huge advocacy role with the government to negotiate so the more money is spent in mental health services to develop them. And I do think the priority should be on the community mental health service. Delivering an MDT, but all the model of care, if you look everywhere in Australia, in UK, in Ireland, New Zealand, so they always kind of focus on the multidisciplinary team effort to deliver care, and they have the best outcome for people with severe and enduring illness. So so there'll be my hope over time in Malaysia, there'll be more investment and more, I suppose, service that are focused on delivery for people with severe enduring illness, because they're technically primary clientele in mental health services. They tend to be the group of people who doesn't work, who needs a lot of support, and needs a lot of input from a specialized services.
Yeah. So now we know what we should do to entice you to come back to Malaysia, right, Fahmi? Okay. How about you, Lou? What is your uh, own personal ambition if you able to do, and what are the things that you wish that Malaysia will be able to do for people who has mental health issues and their family?
I think I would like to see more non-medics specialists in Malaysia. So, for example, mental health nurses, mental health specialized occupational therapists, mental health specialized dietitian, mental health specialized social worker. So basically, it's not only about specialization in the medical field or medical professionals alone. It is about, as what Fahmi has mentioned, a team. So the service is not delivered by the doctor alone. So everyone has a role. So even, for example, specialized, uh, what do we call the experts from who have mental health problem before. So basically, they can share even their experiences. So it's about having more varieties of specialists at the same time, working together, partnership, as what Dr. Hazli has mentioned. So this is what I wish to see in Malaysia if one day I come back and then I have the opportunity is to develop this disciplinary type of professional and also specialist workforce. So this is what I think Malaysia can potentially uh, consider.
Yeah, yeah. I really uh, like when you said that we need more uh, non-medical specialists, non-medical service providers, or the clinical professional which has more trained in mental health. Okay, that's what we want as well, and that's the reason also I invite Sume to be part of the panelists today, because that the intention to let people know that not just doctors, not just psychiatrists who provide services. And then Sume, you should you are consultant. When you said that you are not consultant, no, you will be a consultant soon in your area of specialization, that you provide the service evidence-based, being trained. That the whole idea. We want it to be evidence-based, we want to be trained and accredited, but at the same time not too restricted until we're not able to try something that may be locally, or maybe more feasible in the local setting. But whatever it is, we need to document it. We need to make sure that there are a way for us to monitor and then for the continue improvement in whatever services or program that we started. Yeah, so I think that the whole idea. I also like when Lou mentioned about peer support. That is something that we haven't really have well established in Malaysia. And then one thing that we need to use or utilize is the support from family members or most likely the parents. That's something that we should try to maintain that or try to support that other countries not having that. I think that's something that hopefully we still can keep that and then empower them, support them rather than until let them overwhelm or be burnt out by being a carers. That's something that we need to do to figure out how can we help them because they going to be part of the important team in the multidisciplinary team in the community. So I think that is a really kind of like make the whole messages. I mean, it's like we have a good summary of what the thing that we need to do. And then there is also a comment from Nick Rosaini Jafar. Hey Lou, this is your cikgu tau, your last your past lecturer, and also be with us. This is not easy. She's very busy. And then she make a comment, yeah, in Malaysia, not all GP had psychiatric training. Many rely on their undergraduate training, which is inconsistent. Only those doing PMS training had the more intensive psychiatric training. So even though I think just now Lou said that he doesn't like the word upscaling. Yes, I think we don't use the word that the upscaling because they have the skill, but some of the skill are a little bit rusty already. So we need to polish them and then make them a little bit more, relevant or up to date with the current evidence. So I think in Malaysia, we still need to have a bit both the training and also the collaboration with them, that empower them and then we can work as a partner once they are able to do that. And I believe that they can be a better service providers in a certain aspect or certain cases when it comes to mental health, because I think they can have the niche population that can be a much better suit managed in the primary care than in the secondary care, and then managed by the GPs and the primary care doctors and other service providers as well. For example, occupational, social worker, art therapists, and other non-medical service providers. Okay, without we realize, yeah, we almost come to the end. So it's thank you, guys. Fahmi asking me earlier should do any slide presentation. I said no. People like you guys already as an expert on your own field. No need slides because you just share with your experience, your thoughts. I think that's enough, more than enough. That's something that we always forgot that we are good enough. So that is something that we need to tell ourselves besides telling our client or our patient. Okay, so last before we end, I think I want to ask all of you about this simple question. What does Malaysia Day means to you? What Malaysia Day, Hari Malaysia means to you? Or if it doesn't mean anything, just say that. So we start with Lou. What Malaysia Day means to you? Besides, it's Dr. Hazli's birthday. I know it means a lot, but no, that's not what I want.
So inside this bread is kaya. Malaysia Day is about knowing where I am from, my root, and then where I mean it's always the place I belongs to. The family, okay, and the community spirit that I belong to. So this is what I want to say about Malaysian Day, okay, and of course, uh, I will always be a Malaysian.
Yeah, we are. And Sume,
Yeah, I'm thank you so much for inviting us to do this in conjunction of Malaysia Day. Like Malaysia Day means um I don't know. It's just like a oneness regardless of the colors of our skin. Like we are Malaysian at heart, no matter what our beliefs are, no matter what we look like, no matter where we are. And I feel one thing I wanted to add to Lou's comment about peer support and lived experience is that I would like to see Malaysia moving forward in mental health, really listening to the thoughts, opinions, and ideas that the people who live with mental health experiences have. And I think that's really important.
yeah, thank you, Sume. Thank you for being here. Yeah, I know that you have some other things to do, but you managed to adjust that. Thank you so much, Fahmi.
Um, I suppose one of the good experience being abroad is that I think you're used to be living with the different kind of ethnicity. So as contrary to people may perceive that a lot of the Western countries now they're quite globalized in a way that there's a lot of different people from different countries. Like half of the medics in UK is non-British. They are all kind of so having that, I suppose, perspective that you can see that the issues, all the polarity of racial stuff in Malaysia is not really relevant in where we live, and it hasn't been used as a leverage. It hasn't. So I do think in terms of the aspiration as a Malaysia there is for me is that for people to kind of see beyond that, beyond all this kind of political influences, that and try to kind of and to be able to kind of share those values among all races and ethnicities, and hopefully that something will be a foundation of everything else, I suppose, in Malaysia. And I suppose that'll be my kind of aspiration as part of Malaysia Day.
Yeah. Thank you to all of you. So the idea that about having this, because I know a lot more Malaysians abroad who have what or not something that they want to contribute back to Malaysia. But sometimes the system did not allow it to happen or make it difficult it to happen. And then sometimes something happened that make they don't want to come back. But whatever it is, I think being Malaysians, whenever we are, we still have we call this the place that we call home, the place that even though so long that we've been out from the country, when we eh, uh, reach back, and especially when you take MAS, when the time that to Malaysian will come home, it hit us to the core that it tell us where we belongs. And then we always want to make changes. We always say, oh, I wish that it can be done back home. I wish that I have this back home. I think that, yeah, we can, but maybe the system, a lot of other things beyond our control. But there are small things, a simple thing that we can do. And the idea that we can share like this, despite the different time zone, different places, that we still can have a conversation, have a discussion, have a sharing, even though it seems like just a chit chat between four people who may know nothing about the political what's going on in back scene on who's going to be we don't really care much at the day. We know that we want to make some changes, and we know who the people that may benefit from the changes that we're going to make. And then I hope that we continue having a conversation, and like that for me, like Fahmi, Lu, and Sume, you guys have the knowledge, you guys have the expertise, and then it's such a waste if you not be able to share that with the fellow Malaysian, or the future art therapists, the one who want to be in the to be the family therapist, someone who be the psychiatrist subspecialized in cancer oncology, and then to be the family psychiatrist in the family primary care, for example. And then Lu and Fahmi and then Sume, all of you are very much interested in education, in training. I think that we should do that. We should try to, start how the culture of sharing, the culture of giving. And then hopefully, whatever that we do can be rewarded financially, because we still need to eat, Sume. I know that you don't eat much, but I eat a lot, so I need that as well. So I think we need to take this an opportunity, and how can we can work, we can share, despite that we are not in Malaysia. But what make us we share the same thing? One thing that we share is we are Malaysian, the only place that we call home. So that's what Malaysia Day means to me, where all the Malaysian come together to share what they know, what they wish to know, and then we are good enough to give back. So that is the message that I want people to know what Malaysia Day means besides my birthday. So thank you so much. I think I hope that we can have we meet up again another the same platform but in a different manner so that other people can benefit. So may I have a few people already asking about how to be art therapist. Yeah. So Fahmi, please come back one day. Lu, I know you will come back. And I don't know why, but I think you will come back maybe. I don't know when. Sume, no. Sume is going to be Australian. I'm not for sure. But she still can contribute a lot to Malaysia. Thank you so much for being here today. See you guys around.
It's a
Bye.
pleasure. Thank you.
Bye.
Thank you.
Yeah, thank you to all of you
See
who are
you.
watching
I
this.
think
Yeah,
they
we
wanted to
said
take
thank
a
you so much.
photo. I think they wanted to take a
Take a photo.
photo.
Okay, I think we're going to go off from live. I'm going to share. I mean, going to thank all of you for being with us from already 90 minutes, guys. Thank you for your attention, for your patience. I hope that we give some information to you, and then at least for me, I want you guys to be inspired by these three panelists: Fahmi, Lu, and Sume. Thank you. Happy Malaysia Day. We're going to take picture. Mark, can you stop the live? And then we stay here for the photo. Hello, Mark. Mark, is still live, Mark? Oh, no, Mark.
He said the photo has already been taken.
It's all been taken already. Hello. So how to take photo? I mean, we are still live, right?
Yeah. Yes,
Okay.
yes. I
Okay,
suppose
guys.
so. And then
So anyone know how to take photo from
he
here?
said the picture has been taken.
Oh, okay. So okay, guys. Thank you so much. So it's really.
Thank you,
I mean,
Dr. Hazli.
yeah, and I think the input that all of you share is a very, very good, very good. I think I really appreciate that. It's okay for me, Lou, Sumi.